Thank you for inviting me here. So I'm Karan Jutlla. I'm a reader in Dementia Care and Inclusion, and I actually began my journey in the field of dementia 25 years ago when I was 16, and I've just given away my age. My mum is a retired community psychiatric nurse, so I left school and naturally she got me into a care home to work as a care assistant. And that's when I was first introduced to this idea of supporting people to live well with dementia. Since then, I've gone on an academic journey where I did my undergraduate degree, went on to do a PhD, looking at dementia care in the Sikh community in Wolverhampton, and I now direct the Centre for Applied and Inclusive Health Research at the University of Wolverhampton, where we've got a cluster of work around supporting health inequalities in dementia care through inclusive research. It's always a challenge to give the last talk of the day, so I'm going to try and keep you engaged for the next half an hour or so. And what I'd quite like to do, I'm hoping that this serves as a nice summary for today, because I'd like to demystify what we mean by equality, diversity and inclusion. We use the term a lot, but we don't ever really break it down. Give you an overview of the current evidence base when we think about health inequalities in dementia care. I'd like to use my own research with South Asian communities as an example about what some of the current challenges in practice are when we think about a workforce perspective, and also help you to recognise the importance of training and education in cultural competence in dementia care, and consider the importance of how we could achieve inclusive dementia care practice via a person-centred approach. So it's a big ask within around 20-25 minutes or so. Okay, so apologies if this feels like I'm repeating things that people already know, but like I said, I think it's really important that we break this down. So equality, diversity and inclusion, also known as equity, diversity and inclusion in other countries, refers to ensuring fair treatment and opportunity for all. Now, the term itself, equality, is quite a contested term, as my colleague Chris Nifton pointed out in his presentation, and is quite often not used by a lot of people. Now, in the 20 years or so of delivering training and education on cultural inclusivity and competence to health and social care organisations, I've often asked them to just tell me, how do you know if you're being inclusive in your practice? And you would be surprised, or many of you won't be surprised, at the amount of times they say, because we treat everybody the same. Now, as this image demonstrates, treating everybody the same puts people with certain characteristics at an unfair disadvantage. Equity, on the other hand, involves making the necessary adjustments and adaptations required to make sure that people with different characteristics have a fair opportunity at the same goal or whatever the set activity is. Now, whilst we are working towards more equitable services, what we ought to be doing is really identifying some of those systemic barriers and removing them to achieve true liberation and justice for people. Unfortunately, the reality of the world that we live in is one where certain groups of people get more than what's required and other groups of people get less of what's required. And this sometimes can depend also on what's known as the postcode lottery, depending on where you live. And we know that there are huge disparities as well within and amongst different communities, just when we look at the evidence base based on health inequalities in dementia care. So just as a snapshot, we know that there is low representation in dementia services from people from ethnic minorities, LGBTQ+ communities, people who live in rural locations. We know that there are a higher proportion of women in caring roles than men. We know that, and people have been speaking about this a lot today, there's a lack of support for people with younger onset dementia. People with rarer forms of dementia as well doesn't get talked about quite often, and also people with dementia and learning disabilities or intellectual disabilities. COVID-19 has put a lot of people at an unfair disadvantage due to the lack of digital literacy skills. We know there's a lot of research focusing on ethnic minorities that talks about inappropriate care coupled with language and cultural barriers, and often these can lead to a late or misdiagnosis for many people. We know from the research that there are experiences of subconscious bias and indirect and sometimes direct racial discrimination in services. We've heard a lot as well today about some of those socioeconomic disadvantages and how they lead to that social exclusion cycle, putting people at higher risk of developing dementia. And we know as well, and particularly in a lot of the more recent research, that what makes it even more difficult is that the people that are experiencing these health inequalities are less likely to take part in health and social care research studies, including clinical trials. So now a lot of work is being doing to encourage those people to come forward so that we can understand and support people to know what works for them better. Now, the UK has the Equality Act, and that's why we have equality in our definition of equality, diversity and inclusion. And we can argue that due to the cognitive and sometimes physical disabilities associated with having a diagnosis of dementia, that people with the diagnosis fall under the Equality Act. But it's never as simple as having one particular condition. So you could be somebody diagnosed with dementia. You could also be from an ethnic minority background. You also could be someone who's part of the LGBTQ+ community, and therefore you experience discrimination or unfair disadvantage in a number of different ways. And this is a concept known as intersectionality. And what we do is we try to understand people categorically within the groups of how we can support them better. But actually, we need to start to understand that people experience what we call double or triple jeopardy, and that they may have these experiences for a number of different reasons associated with their identity. So it's never just as simple as understanding one particular community. Now, what I found fascinating in the years that I've been in research and education and training is this notion that if we focus on a diverse workforce, we can start to reduce some of those cultural and language barriers that we see in services. And the idea is that if we've got more people from diverse backgrounds, then we can start to bridge the gap a little bit. You're doing this. We can start to bridge the gap a little bit, I know. So what I want to do is just share with you some direct quotes from some of my recent research projects, some which have been funded by NIHR2, to understand people's lived experiences and what they think about this. And we've got some conflicting views when we speak to people. These are pseudonyms, by the way, so they're replacements that people chose to maintain people's identity. So Jess, age 31, cares for her mother with a diagnosis of dementia. When I spoke to her about her experience of services and what she needs, said, "Mum needs someone she can relate to. If she speaks her language and understands the culture, then it will help her feel connected. How can someone come and give her personal care when she can't have a conversation with her?" So for some people, it's as simple as that. Val, on the other age 56, cared for her mother. She said, "We had a really good Nigerian lady. She was funny, compassionate and caring. She just knew how to connect with Mum, even when we didn't. She understood dementia, and I think that's what really helped." There was always this struggle between either having someone that could reduce the cultural and language barrier but didn't really understand dementia, or the person could understand dementia but there was cultural and language barriers, but never somebody who could do both. And a lot of people were very sort of ambivalent about which one is more important than the other. There's always a focus also on the need for personalised care as well. Balvinder Kaur, age 32, told me, "I still can't believe that services still think that all Asian people are the same. They sent me a Gujarati speaking care worker, my mum speaks Punjabi. They are two completely different languages, but in their eyes we are South Asian, and they sent me a South Asian care worker." And this used to happen to me in care a lot. I remember being one of 3 Asian care workers in the care home that I worked. And the manager often saying to me, "Oh, can you go into Mr. So-and-so because you're Asian?" And I was like, "But I don't I don't speak that language. My language is completely different. And sometimes there'd be cultural barriers there too. They'd say, Karen, can you go and provide care to Mr. Singh? And I'd say, no, I can't give him personal care because he's older than me and that will offend him. Because in our culture and a lot of other cultures, South Asian culture, someone who's older than you refer to as uncle. It's a relationship status, so it would be like his niece trying to wash him and undress him. So it was something that I was never comfortable with, but something that the organisation always thought would work particularly well. Harbant's Kaur, she was aged 70 years old, and she removed her husband from daycare because she said when he used to go to daycare, they just assumed that he wanted Asian food and that he wouldn't be interested in the fish and chips they served every Friday. But we've always eaten fish and chips on a Friday. The children used to love it. Little things like this kept happening, and I felt bad for him. The intention was good, but in trying to meet this gentleman's needs, they unintentionally discriminated against him. So there was no questions asked there, and it's nobody's fault. We see a lot of people in practice who want to meet people's needs and get it right to a point where they've now become slightly nervous about it, and because of that forget to ask the questions. So there's huge need for personalised care. If we go one step further, we spoke a lot today, and it's been great to hear. It's been so uplifting. This need for compassionate care, this need to connect with people, this need for empathy, the need to be kind. And that's something that always comes out. Amrit Kaur, she summed it up really well. And she said to me, I was really struggling to look after my husband. It was hard. I couldn't do everything, so I got help. We had a care worker who was from our community. At first I was happy because she can speak Punjabi, which would really help me. But after a while, she kept making comments about how I needed to help look after him and the things I should be doing, like making his dinner. She was judging everything, so I asked them to send me someone different. I didn't care whether she could speak Punjabi or not. I just wanted her to be kind and understand how hard it all was. And then we've got the people that go, no, I don't care if they can speak my language or not, because I don't want to be judged. And I used to hear this a lot. Please don't send me someone from my community because they'll come in and they'll judge me, and I don't want that. And again, I'm not giving answers here. I'm just sharing these experiences with you to help you see what people's experiences of them are. Now, what about care homes? Care homes are interesting because the idea of not wanting to put your loved one into a care home is a very universal concept. Nobody wants to do it. To an extent, there's some stigma attached to that. But in certain ethnic minorities, it tends to be a little bit more prominent. So Ram Biari, 44 years old, I'll read this one out. She said to me, with us being Indians or Asians, it's like the shame if you turn around and say that I can't cope with looking after this person anymore. If we turned around and it got to the stage where dad needed feeding, washing, medication and bedpans and whatever else, I don't think my husband can do it. And to tell you the truth, I don't know if I can do it. So it would mean putting him into a home, and it would be the shame of that. People would actually point their finger and say, look at what so-and-so's son did, threw him out of the house. And I think that is a community attitude, whereas I'm not saying it doesn't happen in the white population. I'm sure things like that would happen, but people are more objective. But then, stepping aside from what the community has to say about it, when I think about having to put dad in a home, and that time may well come, I think, well, how will he cope in a home when they're mainly set up for white people? His needs are different, the foods he eats, the way he does things, his language and all that. So I guess it's a no-win situation, really. I'd like to share with you an example that happened in practice. It was part of a project that we developed, actually funded by the East Midlands Clinical Research Network, where we developed a toolkit for engaging with people in health and social care research from ethnic minorities. And from that, we developed a real-life case scenario that was actually shared with me during an education and training programme. So they developed a small animation. I apologise, it's my voiceover, so you won't get a break from that. But I just thought it would give me a breather.
A care home in a predominantly white British area had its first Muslim resident. She was fluent in Urdu and understood basic English, although couldn't speak it very well. Although after a few months the carers developed good relationships with this lady, the difficulties in communicating with her were becoming apparent. The care home therefore advertised for an Urdu-speaking care worker to ensure that she has access to the same quality of care as the other residents, and they were successful in the appointment of a female Urdu-speaking lady who was also Muslim by background. By now, the resident had her routine and had settled in well. On a Friday evening, she liked a glass of red wine and would often sit and listen to music. One Friday evening, she was sat with her glass of wine and the newly employed Muslim care worker approached her and told her that the wine is haram and she will go to hell.
That hasn't been a very easy example to share with people, even though it was true, and people have had arguments over this in the audience, but it happened. It happened. And what it emphasises is that cultural biases get taken into practice, and the responsibility that we have in it, that managers have and that we have in health and social care organisations to ensure the correct level of training from people is given, particularly in cultural competence. Now, I speak to a lot of through research and through the training to care home managers, and here's some of the things that they say to me. Current challenges at the moment. Our difficulty now is getting our staff to understand the white British culture. How do we apply the same principles for helping those from an indigenous background to understand ethnic minorities, to helping those from across the globe understand our indigenous population? And just last week, a care home manager said to me, sometimes it can be as simple as understanding what beans on toast is. It's almost like I can see over the 20 years that I've been doing this, it went from helping people to understand migrants living with dementia to helping migrant workers help to understand what the local culture is now for people within care. It's the same concept, but slightly different, if you see what I'm saying. Yeah, am I making sense? Am I making sense at the end of the day? That's right, you're nodding, that's okay. So it's all changing, the issues are changing, but the concept is still the same. So if we break it down, we take a closer look at this. What do we mean by inclusion when we look at it by a definition? It's an organisational effort and practices in which different groups or individuals, that staff, having different backgrounds are culturally and socially accepted and welcomed. Now, the way to be culturally inclusive is to be culturally competent, okay? And this involves the process by which individuals and systems, so they have to work collectively, respond respectfully and effectively to people of all cultures, language, classes, races, ethnic backgrounds, religions, and other diversity factors in a manner that recognises, affirms, and values the worth of individuals, families, and communities, and protects and preserves the dignities of each. So cultural competence is more than having an awareness of cultural norms and defeating language barriers. It's actually a value-based perspective that's about recognising diversity, promoting inclusivity, and respecting individuality. It requires cultural humility because each and every one of us have got our own cultural norms, we've got our own cultural history, we have those stereotypes based on our own upbringing and what we've been exposed to and what we think is right or wrong for people, and we have to unpick that. And it's really important that level of training is given throughout services, and that we do more research to understand how effective that is and what the impact is moving forward. And if we look at things like person-centred care and the notion of personhood, so Professor Tom Kitwood founded Person-Centred Dementia Care, and for him personhood is a standing or status that is bestowed on one human being by others in the context of relationship and social being. It implies recognition, respect, and trust. And you can see how these definitions are very similar to the processes required to be culturally competent when we think about the responsibility that we have to ensure that we are respecting people's beliefs and norms and enabling them to be followed as well. Professor Dawn Brooker later built upon Tom Kitwood's work where she developed Care Fit for VIPs. And she asks these 4 different questions to organisations as well. Again, when we think about that notion of being inclusive in our practice and being culturally competent, she asks us, do our actions value and honour the people that we work with? Do we recognise the individual uniqueness of the people we work with? Do we make a serious attempt to see our actions from their perspective or standpoint? And do our actions provide the support for people to feel socially confident that they are not alone? Which is going back to that very definition of cultural inclusion. So my argument is that the two go hand in hand. You cannot be person-centred without being culturally inclusive. You cannot be culturally inclusive without being person-centred. And just a few questions for organisations to think about when we reflect upon how inclusive that practice is. Just looking at time. And just thinking about, some of the top 3 ways that we can be culturally inclusive based on the work that's been done over the years. We know, especially people that have been working in dementia care, that we must understand and know people's life history. That's one way to do it, because this is something that's always shifting. That we should be practicing self-reflection, absolutely critical to ensure practice is fair and inclusive. I don't think we have enough reflective practice within our health and education courses that we do, which we're starting to try and build in now at the University of Wolverhampton. And I do argue, some might agree, others might not, but if you're working in dementia care, then you should have advanced communication skills. You should be trained in that. A person who is working with somebody who struggles to have that ability to verbally communicate will be creative and intuitive in the way that they can communicate with the person who has the diagnosis of dementia. I still think that we need to build a culturally competent workforce. We need to increase people's confidence, defeat stereotypes, understand what those challenges are, work collaboratively with community organisations, faith groups and families, practice and develop those advanced communication skills. And importantly, we need to have a clear value base so that we are always enabling effective work, effective cross-cultural situations, because you can put 2 people together from the same community. They will be cross-cultural because of the different things that I talked about earlier on when we think about those 9 protected characteristics. I'm Sikh by background, you could put me with somebody who's also Sikh by background, who is a woman, but due to our age, there will be generational differences. So we're always going to be in that cross-cultural situation. Of course, in addition to person-centred care, there are lots of other things that we need to be doing. We do need more funding in this area. It's great to see the SPIND network, and there's so much happening now. I'm actually chair of the Empower network, so it's great to see the launch here today. We need to develop more resources in this area. We need to really pump prime our education and training and make sure we have that research-inspired teaching. Anyone who's in academia will know teaching's over here and research is over here, and very rarely do the two interconnect. And we should be using some of that work that we're doing to inspire our health-related curriculums as well. And hopefully through that start to build a drive more towards culturally competent, a more diverse, skilled workforce. And I say that, with those words in it. So it's not just about diversity. It's not just about doing the survey and showing how diverse your survey is. It's ensuring that they are culturally competent and that they have the right level of education and training. And that we have leaders that have that grassroots approach. We co-produce and co-create through the research that we're doing. And that's how we bring a sense of belonging and inclusion to people, by involving them and speaking with them at the very beginning. And I'm right on time. Thank you for listening.